Hey guys, we're live Facebook Friday, just getting everything up and running. So if you're jumping on and you can see me and hear me, put a chat in the comments and we'll get going. Sorry, just getting everything running here. It just takes a second. Let's see. There we go. Hello, Alyssa. How's it going? Same thing. It's all frozen on the screen there. Let me know if you can see me and hear me on there. What I see looks all frozen and weird, so hopefully it doesn't look frozen and weird to you guys. Hello, Taylor on YouTube. Hey, if you can hear me on YouTube, hey there, Island Girl. Let me know if you can hear me, if it sounds okay. Just still getting everything set up, get this stream ready to go. It's always like 57 clicks on buttons. Hopefully Facebook is not just this frozen weird picture of me that it looks like on my side. That looks a little better. Okay, cool. I think that maybe it's working now. Hello, everybody. Live from Friday afternoon. All right, Kevy says, sounds good. Awesome, thank you very much for that. So, and Laren says, clear on YouTube. Great, thanks guys. Thanks for the info. I think we're ready to roll then. So if you have questions, go ahead, put them in the chat, and we'll get going. Don't have any prepared comments today. I just kind of jumped on here. So really at the mercy of questions in the chat. I did talk a little bit last time about this new medication for postpartum depression. Now the name completely escapes me. I am eventually going to make a video. Hey, Amber, how's it going? I am eventually going to make a video that talks about it in more detail. But for the moment, I'm just kind of floundering, waiting on you guys to ask a question. So, waiting patiently. I realize now that... tell me what you guys think about the vertical on Facebook. I'm trying that orientation just to see if it's better or worse. I don't know if it's better or worse. I'm not so convinced. But if you're watching it on your mobile phone, maybe it's better. I don't know. Let me know what you think on the vertical for YouTube on Facebook. And I can always flip it back to horizontal if it looks weird. Let's see. Laren, am I running the Ogden Marathon? Not a crazy question. Yeah, thank you for any question. I'll take it. Not running Ogden. We're actually going to be out of town that weekend. Thanks, Hillary, for the info there on Facebook. Says it looks good. All right, cool. Yeah, I'm in the middle of training right now for an Ironman 70.3 in Coeur d'Alene, Idaho. So that's coming up in about a month. So got some training going on for that. So couldn't do that plus Ogden Marathon plus we're out of town anyway. Let's see. Alicia says, what's your take on natural birth after L5S1 fusion? Would think it would be fine. I don't think that that's a concern. We have people who've had, rods for scoliosis and other types of things. Your back pain might be more aggravated while you're pregnant. But I wouldn't think in and of itself it's a deal breaker by any stretch. So I think it'd probably be fine. And if you did choose to have an epidural, it wouldn't be a problem because that's lower. They typically do epidurals around L3-4, so L5S1 wouldn't be an issue. Let's see. Shana says, do you have recommendations for birthing classes in the Ogden area? Yeah, so the hospitals do most of that. So either McKay or Ogden Regional, whichever one you're going to go to, we'll have them. All you got to do is just call to sign up for them. Let's see. Amber, we do hysterectomy on somebody who's almost 29. Severely disabled, does headshot. Yeah, I mean, it's, the age is not really a thing. It's more to do with the indications for hysterectomy. So that's kind of a long discussion about why all the various reasons someone might need a hysterectomy, let's say. But, age is, if you're an adult, is not really part of the equation. So, yeah, that doesn't sound like a deal breaker to me. Let's see. Kristen says failed glucose by 9. Do you have to do the 3-hour, or can you choose not to do the 3-hour? Well, it's America. No one's going to force you to do anything, but I'd recommend it. There are implications for gestational diabetes, particularly if not treated, not diagnosed. So I would encourage anyone who didn't pass their 1 hour to go ahead and do the 3-hour. I mean, the only other alternative really is to start monitoring your blood sugars with a glucometer, which is kind of a hassle. You got to do it, 3-4 times a day. Probably easier just do the 3-hour test. And if it's normal, then you're good. Don't have to worry about it. So that'd be my advice. Let's see. Taylor, had another miscarriage since we talked. That was your 4th on Levinox, progesterone, baby aspirin. Protein levels were low. Oh, protein S probably, yeah. Stop the aspirin. Anything else would be good to take? Not really. The only question, and I don't remember, is if you've had the anti-phospholipid antibody workup, and perhaps that's why you're on Levinox and aspirin. But if you've been tested and that's why you're treating you, then that would certainly be appropriate. I'd recommend doing it again. Let's see. Have you come across having Clomid to get pregnant first child? Yeah. So. Basically, the question is about secondary infertility. So previously no fertility problems, and now all of a sudden you do. So yeah, Clomid is one of those things we would certainly use in that situation. So good question. Let's see. Jessica, is there medication for PCOS? Not specifically. So people often use metformin as a treatment for PCOS. It doesn't really fix the underlying issue that is with PCOS, but it can help with some of that glucose intolerance. For some people, it helps them lose a little bit of weight, and that can be useful in PCOS. But aside from that, there's no medicine that's specific for PCOS. It's usually, we're doing things to try to treat the symptoms. So something like spironolactone or birth control pills to try to help with the hyperandrogenism. And then metformin helps with the higher insulin levels. But none of those things actually directly fix the underlying problem, unfortunately. Let's see. Jenny, 23 weeks, having some Braxton Hicks, some days more than others, should be worried. So my, basic concept on contractions in pregnancy is if they're infrequent, then I don't worry about it. But if they're coming and going every 5 minutes for an hour, go to the hospital because maybe you're in labor. So I keep it pretty simple. And if it's not, if they're less frequent than that, then don't worry about it. Let's see. Amber. He was born. Well, thank you very much, Amber. Nice for you to say. All right. Let's see. Sorry, I'm rambling on here reading comments. Okay. Let's see what we got over here. Why do you have to go to the doctor every 4 weeks and every 2 weeks? They don't do much. Just ask you how you feel. It's a good question, So why do we do what we do? That is a continuously asked question, not just by patients, but by me, by other people who think about why we're doing what we're doing. And the honest answer partially is just, that's what we do. There are things that are preventative in nature that we do along the way. And so, and if you've been pregnant, all the different things, and they kind of come up as you go through the pregnancy. And so periodic visits are necessary for those type of tests. So whether you're talking about, screening for chromosomal abnormalities, screening for anatomical abnormalities, screening for diabetes, and then towards the end, you're screening for complications of pregnancy. So, whether that's preeclampsia, preterm labor, any host of things. And then a lot of time is, I think, also spent just sort of education. A lot of time I spend is just answering questions. I mean, one of the things I ask everybody at the start and the end pretty much of every visit is, what questions do you have? And I try to answer those because there's a lot of just questions people have. And so I think that, when you're seen frequently, it gives you an opportunity to make sure all those things are being addressed, and also kind of hitting the preventative things along the way that we need to do. And then there towards the end, when you're coming every week, say in the last month or so, that is mostly just trying to make sure that everything continues to go smoothly at the end, primarily things like preeclampsia, looking for signs of labor, things of that nature. But whether it's, exactly every 4 weeks and then exactly every 2 weeks and then exactly every week is completely just what we do and is not evidence-based. So, but the concept of periodic visits to ensure the health and well-being of mom and baby are what that's all about. So hopefully that answers your question. Let's see. Courtney, 21 weeks, pregnant, pain in your right hip, pelvic area. And what could that be? So depending on the exact location of the pain, it could be either the hip joint itself, it could be your symphysis pubis right in the midline of the pelvis. It could be muscular, so abdominal wall or pelvic floor. Any of these could be a source of pain. And you're right, stretching only helps so much. And that was Jenny, sorry. But that's the SI joint, which is kind of also in the same concept. It's all the joints of your pelvis and low back do move around when you're pregnant, and it hurts. And so I often refer people to physical therapy for some of these things, and that's true whether it was kind of pelvic or hip or SI joint. So those are the kind of things that I typically recommend. I do give out kind of a stretching handout to try first. Recommend things like warm baths and stuff like that, Tylenol. If none of that's cutting it, I typically would refer to physical therapy. Okay. Let's see. Amanda, 2 chemical pregnancies, low progesterone. Would you have start progesterone? So this concept of using progesterone for pregnancy support is basically what Amanda's asking. And the bottom line is there really is no evidence that it works. So I actually don't routinely prescribe it. Low progesterone really mostly is typically an indication of just poor ovulation, ovulatory dysfunction. And so really addressing ovulation on the front end rather than trying to make your progesterone level artificially higher after the fact is probably the way to go. But the bottom line is that as far as pregnancy loss goes, there's no proof that progesterone helps. It's widely prescribed, and if someone's taken it before and they're pregnant and want to take it again, I'm not going to argue with them, but there's just no proof that it does any good, unfortunately. So recurrent pregnancy loss is still one of those things that's very difficult to fully address, and a lot of it probably is genetically based at the what we call it the microdeletion level. So that's like little subparts of your DNA deep within the chromosomes that we all have these little microdeletions, but if you have them in just the right spot, they often lead to recurrent pregnancy loss. You can determine if that's the case with pretty sophisticated gene testing, but it's expensive and it's not really routinely done at this time. But if you want to learn a little bit more about how I do an evaluation of recurrent pregnancy loss, there is a video on my YouTube channel there, Amanda. So check it out. And then if you have questions after that, put them in the chat and I'll be happy to answer for you. Let's see. Thoughts on ablation versus hysterectomy. Both are good. Good treatments for heavy periods. They obviously are different in terms of the amount of recovery that's necessary, the degree of invasiveness of the procedure. So, ablations are outpatient, basically office procedure. You recover within a day or two and generally are fine after that, whereas hysterectomy is more of a 2 to 4 week recovery and really 6 to 8 weeks to be 100%. So that's the big difference. And then the other one, of course, is ablation. It's not guaranteed that it's going to lead to no periods. So, you may get lighter periods and it may ultimately someday fail again. And so, you went through the ablation and then, down the road, sometime you start bleeding again. And those people often wind up just having a hysterectomy anyway. So I think that's important here is to understand that ablations don't always work, and it may work for a while and then it comes back. So that's the difference between that and hysterectomy, where hysterectomy, you do it, you're not going to bleed anymore, but it is a bigger procedure and a longer recovery. So those are the main differences. Let's see. Jenny, is it ever okay to take a low dose of ibuprofen? Not in pregnancy. The only data we have on non-steroidals that we know is safe is a low-dose aspirin. We're talking 81 milligrams to 110, 120 milligrams, which is well below the type of doses that would do anything for pain relief. But there is evidence at that dose for people who have risk factors for preeclampsia. But the concern about taking something like ibuprofen or other non-steroidals during pregnancies, it can affect the circulation in the fetal heart. And we don't want to do anything to mess with that. So that's why we advise just stick to Tylenol. I know it doesn't work great for everybody. Let's see. Tiffany, is there a point in pregnancy you would discourage jogging? Not for a healthy pregnancy. So if everything's going okay, jogging's fine. Different story if you have other complications, preterm labor, placenta previa, bleeding in pregnancy, hypertension in pregnancy. So, any of those situations that we would probably discourage exercise. But for a healthy, uncomplicated pregnancy, there's all kinds of evidence that exercise in pregnancy is beneficial. So, hope that answers your question. Let's see. Taylor's sort of giving us some details about her last miscarriage. Yeah, so sort of the gist of your concept was that the cause of the miscarriage was probably something with the baby, some sort of abnormality, and that's generally true. So the majority of miscarriages are probably related to some sort of chromosomal or, like I said, microdeletion type stuff in the DNA, and that does ultimately lead to miscarriage in a lot of situations. So you're probably right. Sorry that you had to go through that again, but it's and let's see, you're talking about the only testing they'd done was the blood clotting disorder, low protein S, take the aspirin. Yeah, it's not that that's not a bad idea, taking a low dose of aspirin for the low protein S. It's just that that's not necessarily associated with recurrent pregnancy loss. But at least from a prevention of blood clotting, it's reasonable to say take a low dose aspirin like that. So I think that's fine. And generally, like I was saying, that's sort of in the 81 to 110, 120 milligram neighborhood. Okay, cool. I think I just got caught up. So if you guys have other questions, you can put them in the chat, and we'll see what we talk about next. Yeah, I think I'm all caught up. That was quick. All right, well, hey, thanks for the thumbs up on Facebook Live. I know it sounds silly, but for whatever reason, apparently, when you do these kind of interactions, whether either you hit a thumbs up or you make a comment or whatever, it makes Facebook happy, and they put the video out to more people. So thanks for all those as you guys interact with the video. It's helpful. Let's see. At what point do you switch your patients from every 4 weeks to more frequent, generally around 28 weeks? So it's not exact for everybody, but that's the ballpark if you're talking about an uncomplicated pregnancy. All right. Let's see, Taylor, what about progesterone after ovulation? Yeah, we were talking about that a minute ago, but the bottom line is just that using progesterone for history of recurrent pregnancy loss is just not effective. It's just there's no benefit. So people do it, and it's not gonna hurt anything. But when you look at the studies, it's just not useful, unfortunately. And that's also true of low dose aspirin for recurrent pregnancy loss. And it kind of goes back to that underlying thing that we were talking about, and that is that if a pregnancy is either genetically abnormal, chromosomally abnormal, that's something that these therapeutic things just aren't going to address. So it's probably got more to do with that underlying issue, whatever it might be. Let's see, Ashley, can antibiotics make you spot 2 weeks early? If you're on birth control pills and it's a specific type of antibiotic that interacts with your birth control pill, then maybe. And that's why we think that there's only a few antibiotics that I think definitively have been shown to interact. So, you could check with your pharmacist and ask them if whatever antibiotics you're on, if they could interfere with your birth control pill, if that was the case. Thanks for the hearts and stuff on there, guys. That's what we were talking about a second ago. But aside from that, I wouldn't worry about it. But in theory, it could make your birth control pill a little bit less effective if that was the case. Jenny, took Femara and didn't ovulate. Is that normal? It can be. It doesn't work for everybody every time. So sometimes you need to do a trigger shot. Sometimes you need to increase the dose. Sometimes you need more than one round of Femara to recruit a follicle that leads to ovulation. That's why I often do follicle checks with ultrasound. And there's a video on my YouTube channel that talks about that if you're curious, you can watch to see kind of the protocol that I go through when I run a Femara or Clomid cycle. It's called How to Take Clomid or Femara. Very creative. So check it out. Let's see. Is there any reason behind incompetent cervix, genetic, how late in pregnancy can cerclage be placed? Yeah, it probably is genetic. We don't understand it. That's for sure. How late in the pregnancy, generally, we wouldn't place a cerclage after a pregnancy was viable. So, generally around 23 weeks. And the reason as well, concern would be, well, what if you by placing a cerclage in someone who's 24 weeks or whatever, make their water break or something like that, then you probably just cause more harm than good. So we typically do them much earlier in pregnancy. And there's different types of cerclages, and not to get into all the details of that, but for the simplest ones are the ones we do for preventative. So if you have a known history of incompetent cervix in a prior pregnancy, then we do them around 11 or 12 weeks when they're pretty easy to do. The trickier ones are when you're around that 21, 22 weeks. That's when they can be very difficult, particularly if they're done for we call rescue cerclage. Let's see. Have you ever heard of hyperfertility? Yeah, not necessarily. It's not anything that anybody's ever taught me about in 20 years of doing this. So I don't know that that's really a known medical diagnosis, I guess. So let's see. Tiffany says, if you get your tubes tied, is it an option to do an ablation at the same time? No. So the risk of complications would be unacceptably high to do an ablation at the time of a cesarean. And it would be ineffective because the ablation itself wouldn't be able to cover the entire uterine cavity during a full-term pregnancy uterus. It just the ablations are meant to treat a uterine cavity that's not pregnant, so something that's a lot smaller. So wouldn't do that at the time of a C-section. All right, Reina says, "Salud, doctor." I'm not sure what bendiga means, but something always. How's it going, Reina? That's funny. I think I'm caught back up. There you go. Let's see. Yeah, Taylor's talking about this thing, hyperfertility, that they're starting to study in the UK. Never heard of it, so we'll see. Does Clomid have the same statistics as Femera? If you mean like chances of pregnancy occurring from any given round of, say, Clomid or Femera, yeah, probably. I generally say about 10 to 15% per cycle is what you could anticipate from any of these medications. So let's see. How long after giving birth should you wait to try and conceive again? Yeah, I mean, a year is a good number. That's kind of more or less what nature would do. So if you think about, okay, you had a baby and then you nursed, before there was formula or other options, you probably nursed for about a year. And while you're nursing, typically you wouldn't ovulate. And then as you start to wean from nursing is when ovulation returns and you might get pregnant again. That's about a year. So a year between pregnancies, just from thinking about it from a common sense kind of natural standpoint, makes sense. And there is evidence of increased complications with shorter pregnancy intervals, so less time between pregnancies does, increase the risk for certain complications, including growth restriction of the subsequent baby, maybe preterm birth. It's also harder typically to get the weight off from the first baby if you got pregnant really quick after that. So, 1 year is certainly reasonable. If someone got pregnant, 8 months in, I'm not going to freak out about it. But if someone's like, hey, we're going to make a plan, and how long should we plan before we get pregnant again, then a year between pregnancies is a good number. Let's see. Indowner6 says, your OB did a blood test and your lymphocytes came back at 4414. What could that mean? Who knows? It's difficult to know from one individual portion of a lab report what something means. I would ask you to discuss it with your doctor and let them address it. One of the most important things to realize is that without knowing the units that your lab reports in, that could be a perfectly normal number, or it could be perfectly abnormal. There's no way for me to know from just that little bit of information. So my advice, talk to your doctor. Okay, caught up again. Sweet. Is there any real way to gender sway? No, there's not. It's a complete myth, and that's that Shettles method or whatever. It's complete bunk. And I made a video on my YouTube channel that's called like how to make a girl or a boy or something, and I went through all the different crazy things that people have purported to help, and none of them help. So you get what you get, and you don't throw a fit, right? Okay. Taylor was saying miscarriages when your daughter was 3 months old. There's no evidence that miscarriage rate is higher with a short inter-pregnancy interval that I'm aware of. So I don't think it has anything to do with it. It's more about other complications during the pregnancy. I've never read anything that would indicate that the miscarriage rate's higher. Okay. So yeah, can I go to my YouTube channel? I'll type it in down here on Facebook. It's Wes D Ski. If you just type in Wes D Ski on YouTube, then you'll find my YouTube channel, and there's a video on there that talks about, and it's basically looking at all the myths that have to do with trying to have a boy or a girl or whatever. I found it pretty entertaining. All right, you guys, I think I'm all caught up. So if you have a question, feel free to put it in the chat, and we'll see what we talk about next. Oh, I was starting to talk about this new treatment for postpartum depression. I still have yet to see it be used. Brexanolone is the medication. It's actually a progesterone analog. It's different from all the other meds that you could use for treatment of postpartum depression, which are just all the standard antidepressants. It's a progesterone, so it's a hormonal thing, and on the surface you kind of go, well, that sort of makes sense just from a common sense standpoint, because you have these huge hormonal fluctuations after you deliver, and could that trigger mood disorders? And yeah, I mean, I think it certainly could. And this medication is based on progesterone, which is what your body makes a lot of. So it makes sense. The main things to know about it are it's new, it's remarkably expensive, like $30,000 or something crazy. You have to get it in the hospital. You have to stay there for something like 60 hours or something like that. And that's because some of the side effects related are not real dangerous, but like passing out and things like that. So I guess they want to observe people to make sure they're safe before they let them go. So eventually I'll get around to making a video about that, but I'm sure you can read a little bit about it online if you're curious. Let's see. Celine says, what's the process for coming off birth control to try to get pregnant? Just stop taking it. And how long does it take for regular ovulation to start? If you ovulate regularly, normally, probably 2 weeks. So most people will ovulate within about, start the process of recruiting a follicle within about 7 days of stopping a birth control pill, which if you think about it, that's why there's only 7 days of placebo pills in your standard birth control pill pack. Because if you go longer than that, you might start to ovulate, in which case too late. So that's why the 7-day thing on birth control pills. So pretty much I tell people just take it till you're ready to get pregnant, and then stop it when you're ready to get pregnant, and just figure it could happen anytime after that. But there's no like washout period or waiting period or anything like that. Amber said she's just pregnant and have been craving Ritz Bits with cheese. Is that safe? Yeah, it's fine. Jeff says, are they really giving marijuana for postpartum? Not that I'm aware of. Trisha, is it normal to feel numb emotionally while pregnant? Don't feel depressed, real highs or lows, just almost like you're on a mood pill, but you're not. Not necessarily. I think that's one of those discuss it with your healthcare provider and kind of dive into it a little bit more deeply than we could do on Facebook Live. Jenny says, craving brie cheese and blue cheese. Is there any risk you should be worried about? Some say no soft cheese. The main concern is that if you were to consume unpasteurized dairy products, which some of those soft cheeses are unpasteurized, that's the concern, because if you consume unpasteurized dairy, you have a risk of listeria, it's a bacterial infection, and that can cause pregnancy loss. That is a real thing. So that's the concern. Now, if it happens to be blue cheese that's pasteurized, it's fine. It's not like there's anything specific to that cheese. It's just all about the pasteurization. So, if you can confirm on the package that the cheese has been pasteurized, then it's fine. And if you can't, then I'd avoid it. I can't honestly say that I've spent a lot of time looking at cheese labels to really know which ones are pasteurized and which ones are not. But I suspect the majority of ones you can buy at Smith's or whatever are pasteurized, because you typically can't get like raw dairy products from a normal store. You kind of have to go like to the farm and get it from the farmer or from the cow. But just look at the package, and if it's pasteurized, it's fine. Okay, let's see what we got over here on YouTube. Music, Feel the Beat. That's a great name. What are the possibilities of having a normal pregnancy after an ectopic? How long should you wait to try to conceive? What are major symptoms? Well, the symptoms of ectopic pregnancy are kind of vague and are similar to that of a miscarriage. So bleeding and cramping, little pelvic pain, things like that, which is why anybody who's early pregnant and hasn't been confirmed to have a pregnancy in their uterus and is having bleeding or cramping should absolutely seek medical care, because one of the things you do want to rule out in that situation is an ectopic. Now, in terms of like what's the chance of having a healthy pregnancy after you've had an ectopic pregnancy, the short answer is it depends. If you had one ectopic and it was treated either surgically or medically, and did not rupture and resolved, with sort of no drama, then there is an increased risk of ectopic in a subsequent pregnancy, but it's not a huge increased risk. So maybe it's like 10 or 15% for one ectopic. Now, if you've had two, the risk pretty much doubles from there. So now you're looking at maybe 20, 30%. And by the time you hit 3, you're way up there. So if you've had 3 ectopics, it's like, I'm making this number up, but it's like 60, 70% chance of another ectopic. It's very high risk at that point. But if we're talking about after just one, odds are you're going to be okay, but you're definitely at higher risk than people in the other sort of unaffected population. And so anybody with that history, my advice is always, as soon as you realize you're pregnant, you ought to be getting blood levels. We call those quants, or quantitative beta HCGs. And those we would follow until you get up to levels where we could expect to see something on an ultrasound, and then you have an early ultrasound. So that's what I would recommend. Hopefully that answered your question. Okay. Looks like I've answered all the questions again, so I'm just waiting to see what else you guys pop up there. But for the moment, I think I'm all caught up. While we're waiting, I'll jump over to my YouTube channel and just see what kind of questions have been coming up in the comments section of my videos. That's often a good place to find things to talk about. And I can't get logged on. All right, well, just kidding, never mind. Okay, well, just waiting on a question. If you guys have one, hit me with it. Let's see, here we go. Thank you, Charlene. Sister has high testosterone, PCOS before she got pregnant. She's 5 weeks. Is there anything she can do? Well, if she's pregnant, congratulations to her. And there's really nothing that, from a PCOS standpoint at the moment, that she needs to do. So the main thing is if you have PCOS, you have a little higher risk of gestational diabetes. And so we tend to test those patients earlier in the pregnancy than the normal. But aside from that, there's not anything special she needs to do for the moment. Just congrats to her, and hopefully things go well. Taylor, is it okay to take Lovenox during ovulation? Will it affect the egg at all? No, it won't affect your egg. You don't really need to take it, while you're ovulating. Generally, if I was going to treat somebody with Lovenox, say for recurrent pregnancy loss, I just tell them to wait until you're pregnant. Just because you don't need to be on it right now. There's no benefit while you're not pregnant. I don't think it's harmful. The only kind of sort of theoretical thing is, if you ovulate and had like a hemorrhagic ovarian cyst and now you're on a blood thinner, in theory, maybe it would increase the risk of bleeding into that cyst a little bit. But that's kind of theoretical. So he said, Dr. Walsh on it 4 weeks after miscarriage, decide again, try for it. It's fine. Like I said, I just don't think that it's particularly beneficial until you're actually pregnant, but that's okay. Let's see. Screen name IDK says, hemorrhaged after vaginal birth, multiple opinions for different OBs, recommended C-section. Yeah, I don't know why you'd need a C-section for just a history of a postpartum hemorrhage. Maybe there's more to it than I know from what you wrote down there. But I'll just make up a scenario and say that if I had a patient who had an uncomplicated vaginal delivery, who had a postpartum hemorrhage, I would not recommend they have a C-section just because of that history. So I don't know what they're getting at there, unless there's more to it that you can tell me. Because you're right, C-sections definitely are a higher risk for hemorrhage than a vaginal birth, no question. Okay, all caught up again. Let's see, how normal is it to have cramping in your ovaries in general when pregnant? Cramping in general. Well, I mean, yeah, sort of pelvic pain in general when you're pregnant is definitely normal. Kind of anywhere in your abdomen at some point is fairly common. Now, in early pregnancy, of course, it's going to be low, kind of pelvic area where someone might say it felt like it was their ovaries. They might have that round ligament kind of pain. But by the time you're, say third trimester, I mean, it can hurt anywhere in your belly. And that sort of leads me to my, what's my thoughts on just abdominal pain in pregnancy. And I've kind of boiled it down to this. If you're bleeding and you're having pain, that's a concern. If you're just having some random sharp shooty pains and no bleeding, it's probably fine. If it sounds like labor, get checked for labor. So if you're having pains that come and go, like every 5 minutes for an hour, well, you might be in labor, so that'd be something to get checked on. And then do you have any other concerning symptoms, like do you have a fever, or do you have nausea with the pain? Having any problems with your bowels or digestion or anything? Because any of those might make you think about something else. If you're having urinary symptoms, then maybe it's like a UTI. But if it's like none of those things and it's just occasional sharp shooty pain, don't even worry about it. Let's see. Okay, so IDK said just had a retained placenta, nothing crazy. Yeah, I wouldn't recommend a C-section for a retained placenta. That's my opinion. You asked for it. There it is. Let's see. How supportive are you to a very natural unmedicated? Yeah, it's fine. I mean, it's free country. So you can be as I like very natural versus very natural. I'm not sure how to define that, but yeah, I mean, people have unmedicated births all the time. More power to them. I wouldn't do it, but it's not about me. So both hospitals are certain. Both hospitals that I work at, so McKay and Ogden Regional, are very supportive of folks who want to go unmedicated. McKay has a really nice kind of homey little birth room with a nice big tub, and it's kind of decorated, not so hospital-ish. So especially at McKay, it's kind of easy to do that. They have pretty good support at McKay for like hypnobirth and stuff like that. So if you're into that, which for certain people works really well, I will say. I've had some patients who did hypno and it was just amazing. And then other people who did hypno and, it gave them something to do while they got their epidural. So, whatever. But certainly, I think anybody who delivers babies is okay with doing an unmedicated delivery, I would hope. Let's see. Aubrey, postpartum bleeding and clots, when do you need to worry? What's normal? Yeah, so basically it's all about like, when is it heavy? So if you're soaking through a couple pads an hour for more than a couple of hours and it's not slowing down, that's what's heavy to me. So if you're hitting those kind of numbers, then that's when I'd say you need to seek medical care. But if it's just like you're not soaking them, it's not that heavy, yeah, you see some clots, but they're not that big, then I don't worry about it. It's fairly common to have bleeding that kind of comes and goes while you're postpartum. Especially after you nurse, you may see a little clot come out, that kind of thing. So as long as you're not going through a couple big pads an hour for more than an hour or two, then it's probably fine. Let's see, how much exercise is acceptable? Yeah, pretty much what I tell people is, with a few exceptions, if you're used to doing it, you can keep doing it. So, I mean, I've had patients who, they were kickboxing instructors or did CrossFit or aerobics, or I even had a patient who was training for an Ironman. So it's really more about your own sort of baseline level of fitness. There are some things you probably should avoid while you're pregnant, like particularly third trimester. I wouldn't recommend doing exercises where you're flat on your back, because that will potentially compromise blood flow to the placenta, and that could, be a problem for the baby. And I always recommend, like, don't do like crazy heavy squats and stuff like that. That might not, you could, pretty easily throw your hip out or hurt your back or something. But like cardio is good. Do it. There's no magic heartbeat below which you need to stay. So people say, oh, keep your heart rate below whatever. There's no evidence whatsoever that matters. Generally speaking, I think your own level of fitness will dictate your heart rate. And if it gets too fast, you'll slow down. So yeah, I definitely encourage people to stay physically active. Some of the best deliveries that I've had in life were people who were fitness buffs. So I have a patient that I think of that was big CrossFit, and she just had a baby like it was nothing. I had a patient who was a kickboxing instructor, same thing. So I think the more fit you are going into delivery, the better, because clearly, labor is an athletic event, and the better shape you're in, the better. Let's see. Got some questions here on severe postpartum depression. You can certainly see your OB. I think that's always the easiest place to get in. If you already have an established relationship with a family doctor who is treating you or a psychiatrist, that's also totally fine. But when you're having prenatal care and you're seeing your OB frequently, especially there at the end, then you guys have a relationship. And so it's probably pretty easy to get in with them, because I think more than anything, it's just about access. And so I would definitely encourage you to follow up with one of them, and any of them are fine, whichever one is easiest to get in with. Let's see. Leonardo says, what's the normal range for progesterone? It depends. Your wife's progesterone was 0.6. That's low, but it depends on where you were in the cycle. Are you pregnant or not? Things like that. So that's one of the problems with this concept of, like, quote unquote, checking hormones. It totally depends on where you are in the cycle. Are you pregnant or not? Are you on hormones? Excuse me. There's all kinds of variables. So it's very hard to just give a judgment based on one lab level. It was this. What do you think? Hard to say. Let's see. Okay. Rachel, can you carry on horse riding? Yeah. And this is a common question. And the main concern, I think, is just, well, what's going to happen if you fall off the horse? So, and I know horses are still at heart wild animals, and, unpredictable possibly, and things can happen. So I think that's the main risk of something like that is, you get thrown by your horse and you're 30 weeks pregnant. That could cause a real problem. You could be at serious risk for placental abruption, preterm labor, stuff like that. So that's the main concern. Now, if that happens at 12 weeks, it's not going to hurt the baby. I mean, you might get injured, but the baby's going to be okay. So it also depends a bit on, where you are in the pregnancy. Hopefully that helps you answer your question. Let's see, Jenny, at what point is it important to make sure you're sleeping on your side more than your back? Definitely after 28 weeks. There's a video on my YouTube channel that talks about this study that goes into it in detail, but basically that study showed that if you were a back sleeper, someone who fell asleep on their back, then that group of people had a higher risk of stillbirth than people who were not back sleepers. So I do encourage folks, certainly in that third trimester, to kind of prop up with pillows, do what you got to do so that you're not flat on your back. And if you want to learn more about that, check out, there's a video on my YouTube channel that talks about it in some detail. Let's see. Hey, Penny from England, visiting family. That's awesome. Let's see. Rachel, have been told to give up trying. It won't happen for us. Well, I never tell anybody to give up. So I don't think that's good advice. It's hard to know, without more detail, what should you go to next. But, there's always, for most people, there's always other options. So, even all the way out to like in vitro, or even using, donor embryos, donor eggs, donor sperm. There's all kinds of things that can be done. There's even surrogacy. So, there's all kinds of ways to get around fertility problems. It just kind of depends on the individual situation. But one thing I never tell anybody is, well, just give up. So I'm sorry you've been told that. Let's see. Can low progesterone cause an irregular period? Yeah. And it's more about, like, why is the progesterone low in the first place? So if someone's not ovulating regularly, then their progesterone levels might be low. And that certainly could lead to an irregular period. So there's one scenario where the answer to your question is yes. Hopefully that's helpful. Cool. All right, we're caught up. So we've been going for like 45 minutes already. It's crazy. So if you have a question, put it in the chat. We'll maybe go for 5 or 10 more minutes, and then we'll probably call it good. Waiting patiently. So Penny, what are you doing in England? Visiting family. Where are you in England? What's it like? What's the weather like? What time is it there? It must be like 10. Gosh, it must be like midnight there. Let's see. Feel the Beat says, I had gestational diabetes, previous pregnancy. How do you know if you might be at risk? Yeah, you have risk because you had gestational diabetes in the past. This is just me personally. My usual kind of protocol for that is I test people when they first present in the subsequent pregnancy. And if it's normal, maybe check again around 20 weeks. And if it's normal, check again at the usual time, which is 28. But the idea is you test those patients earlier because we do know they have a higher risk. And obviously, the sooner you can get on to making the diagnosis and treatment, then the better. So that's my logic. Birkenbag says it's 11:39 p.m. in the UK. There you go. That's nuts. You guys are up late. Rachel says your age, miscarriage. Well, like I said, you said fertility options aren't an option. Got it. Yeah. It's wet and horrible in the UK. Well, I'm sorry to hear that. That's a bummer. Penny's visiting grandmas. They're both 96. Man, that's awesome. And a cousin who's getting married. Well, that's cool. Congrats to your 96-year-old grandmas. I had a grandma who almost made it to 100. She got to 99 and then didn't make it to her next birthday, sadly. So good for you. Both your grandmas are still alive. That's pretty amazing. Got some good genes there. So wet and horrible. I think it was it rainy for the London Marathon? We had some friends who did it. Is metformin okay to take during pregnancy, and how much? Yeah, metformin's fine. Usual dose is about 500 milligrams twice a day. It's often used for gestational diabetes. Sorry. Okay. Birkenbag says natural family planning thoughts. Kind of works. So, basically if you're able to know when your fertile window is because your periods are regular, then avoiding that fertile time will be fairly effective, probably in the 85+% neighborhood. Nothing's 100, obviously. So the most fertile time is in the 5 days leading up to ovulation. You could certainly get pregnant outside of that window. So if you said, well, call it kind of the 10 days around ovulation, maybe the 5 before and the 5 after, something like that, then you've pretty well got your bases covered. And that's assuming that you have regular periods, and that's assuming that you know when you typically ovulate. Excuse me, there's some assumptions there. But if you know those things, then you can pretty well avoid the fertile time. It does take out a fair amount of time each month, but that's okay. So, it works for the most part if you know when you're ovulating. Good question. Okay, Penny said weather's been okay, raining. She's in Hampshire. Hoping the genes got passed on. I know, right? Yeah, I'm hoping. I don't know, though, honestly. What's it like to... My grandmother, who was 99, was not living her best life. God bless her. So, I guess if I could be 99 and like totally spry and still doing half Ironmans, I'm in. But if I'm stuck in a bed and can't really do anything and don't really know where I am, I'm not sure I'd want to sign up for that. But everybody's different. I'm hoping your grandmas are spry and doing half marathons still. I want to be that old guy. Look at that old guy. He's still out there. Okay. Bethany, hey. I'm digging the hair. Oh, thanks. I'm due for a haircut. It's like totally way too long. Haircut tomorrow. Let's see. Is it normal to have a period every 5 weeks? Well, that's a little bit longer than average. You figure that means you got about a 35-day cycle. It typically is all about when you ovulate. And so typically you'll have a period about 2 weeks after ovulation. So that means that in general, you're ovulating about a week later than average. Which could get back to making it a little bit more difficult to cover your bases with the natural family planning. But, if at the end of the day it's regular, then it's, I guess, normal for you. The one that's sort of definitely not normal is if you're missing periods. So, they're 40 days, didn't have a period, or 80 days or whatever. Well, those people are are not ovulating regularly, a lot of those are PCOS. But if yours has always been 5 weeks, that's just you probably, and so it's probably fine. Rachel, periods vary from 22 to 26 days, different day every month. Are these regular or irregular? Well, I mean, it just sounds like you're not ovulating super regularly. And that can be, whoops, sorry if I bumped to the microphone there. That definitely does potentially lead back to egg quality and ovulatory dysfunction and fertility problems and all that jazz. Yeah, and aware of ovulation with lots of cervical mucus. Yeah, that really is the best predictor of ovulation. So you're right. The only catch is that sperm may hang around long enough that even though your mucus hadn't changed yet, so there's still a chance. But ovulation prediction really is best documented by changes in cervical mucus. It's true. Let's see. Grandma painted her benches in her garden last week. That's great. Still travels. She knits baby booties. That's awesome. That's great. Sounds like she's having a good time. Good for her. Tips for sore breasts before period. Yeah, caffeine intake is one of those things that you can modify. So the more caffeine you have, the typically more soreness in the breasts you might notice. Some people think that vitamin E supplementation helps. I've never seen a study that actually proved that it was true, but I've read it in some various places. So maybe checking a little vitamin E supplementation. Making sure you're wearing a good fitting bra seems to help. There's one study that showed that a properly fitted bra reduced breast pain. So that's one to think about. Where to go to get properly fitted for a bra, I have no idea. But that's what the study showed. All right. So, consider turning down video. I don't know what that means. I'm getting some kind of weird encoding error. If you're watching on YouTube, is it jumpy or is it smooth? Because I guess it is a little jumpy. I'm looking at it. Probably sending too much data down the pipe. I'm still trying to figure that all out. Let's see. Evening primrose oil. Yeah, it can't hurt. Ovulate around day 10. Yep. So you'd figure that based on your shorter cycles. Alicia says cycles vary 28, sometimes 90 days. Nothing regular. Yeah. Tried Femera. Negative. Yeah. So it's all about, ovulation, of course. And, there's a video on my YouTube channel there, Alicia, that talks about how I do Femera or Clomid. So you might look at that. I mean, I often would do follicle testing in your situation to try to document when you're ovulating. So you might consider that. But check it out. I talk about it in some detail on the on my YouTube channel there. It's under the playlist called Infertility / Trying to Conceive. And the name of the video is How to Take Clomid or Femera. So maybe check it out. All right, and thanks, you guys say it's coming across smooth. Excellent. Thank you very much. I don't know, it looks a little bit jumpy on my side, so I'm glad you guys have got smooth. That's excellent. Good. All right. Real quick, let's see. I know I had somebody on earlier from Italy. I know I've got people on here from the UK right now. Is there anybody else that's watching from exotic locations? One time I had somebody on from New Zealand. I think that was last time I was on live. So how about anybody else or locally? Where's everybody watching? I know I've got some Utah peeps on here. Then there's the pause. So I say it and then it like goes down the pike and then it comes to you guys and then you respond. So like in 3 minutes, I'll start seeing your responses from where you're watching. Let's see. So you did a follicle scan on day 13. You had a 21 millimeter. Yeah. So 21 millimeter follicle is right on track. That's where you wanted to be. So that one was good. South Africa. Holy cow. Okay. You win today, Alicia. You win the prize. Buffalo, New York. Wow. That's out there too. Not as far as South Africa, but pretty far. I have been to London, Idaho. There you go. Hey, we're going to Coeur d'Alene in about a month. So there's a half Ironman in Coeur d'Alene that we're doing in June. My wife and I. We have been to London. I enjoyed it. I wish I'd had more time there. We stopped over in London for a few days on the way to Crete, which was pretty cool. and spent a couple days in Santorini while we were there, which was amazing, but really hard to get in and out of Santorini. Yeah, we were there. We were in the UK in the summer, and it was fine. It wasn't any big deal. Had a nice run along the river there, the River Thames, and saw the crazy building. What do they call it? The Gherkin. Saw that, and York, UK. There you go. That's awesome. So yeah, we'd like to go back though. The funny thing was we stayed in this hotel right in the West End, and there was a wedding, and the party went on all night long. Mountain View, Wyoming. Yeah, that's awesome. We have a lot of people who come from Wyoming. It's amazing. Thank you. That's a heck of a drive. How do you say that? Solahol. Solahol? Is that right? I have no idea. All right. If you guys have any medical questions, we're just talking about locations in the world now, which is awesome. That's amazing to me that, I turn on a camera and I'm talking to somebody from the UK and talking to somebody from South Africa. South Africa definitely is on the bucket list for sure. Definitely want to go there. It's a long way from here, but it's definitely on the list. I keep telling myself that my wife and I are going to go there after we get our son out of the house. So that's a couple years away maybe, but definitely on the list. All right. Okay, I'll give another minute. If you have any medical questions, put them in the chat and I'll answer them. And then otherwise, I think we'll wrap it up because it seems like we've run out of things to talk about. But it's been a good one. We've been going live for, basically an hour now. And once again, a thanks to everybody who put their questions and who's watched, because otherwise I'm sitting here babbling about nothing. I really do enjoy doing these things, and I appreciate you guys jumping on with me, and I appreciate your questions. I'm not seeing any other questions popping up, so I'm thinking maybe we'll just wrap it up right there. So thanks again. I hope everybody has a great weekend, and we'll catch you on this the next time we do it. See you on the internet.